everybody, and welcome back to another episode of the Built for Growth podcast. Today, I have Jeremy Manuele, or better known as Dr. J. He's an orthopedic doctor, and he specializes in skeletal maxillary expansion. I didn't know what that was before talking to Dr. J, but today we discuss the reduced size of the upper jaw and the things that our modern lifestyles do to contribute to it, and why it's a problem, how it is leading towards mouth breathing. So, my fellow mouth breathers, I consider myself a recovering mouth breather. You're doing yourself a major disservice. Mouths are for eating, noses are for breathing. And for the simple fact that we produce nitric oxide from our noses, and guess what? It's a natural anti-inflammatory. And there's so many other negative symptoms to continually mouth breathing. Such things as disrupted sleep, snoring, sleep apnea, grinding your teeth can be a symptom, dry lips, dry mouth, and even allergies. Now, that one really blew my mind because come to find out that nasal breathing can reduce the immune system's response because just that's the way that it was supposed to work. You're not supposed to breathe in all these allergens into your lungs, which then causes an over response of the immune system in a nutshell. And we go into all of that in depth, and he explains it much more eloquently than I will be able to in this intro. But I do want you to know that the good news is if any of this sounds familiar to you or to anyone that you love and care about and want to hopefully share this episode with, which I would greatly appreciate, there are some things that you can do about it. So, listen up, put your listening ears on, as I tell my kids, and we're going to teach you. We're going to show you all the things, or I should say Dr. J is going to teach with you. I will share anecdotal stories as per usual. But I want you to know that some things about Dr. J, like the fact that he's a Las Vegas native, so he lives right here in town, and he earned his bachelor's degree of science and Doctor of Dental Medicine degrees from UNLV. He completed his orthodontic residency at Louisiana State University Health of Sciences Center, receiving extensive training in all aspects of orthodontics. Dr. J has he has a private practice where he provides this non-surgical approach, which I love, and he really addresses the root cause. And that's what this is all about. We are trying to not just accept and stay complacent and change, right? We don't just want passive change. We want growth, right? That's why you listen to this podcast. So if you want to go online at any point, either during the podcast or after, you can go to vegasorthodoc.com and you can have a consult with Dr. J anywhere in the world. It's really cool. The technological advances that are allowing these things to happen. So, as always, you guys, thank you so much for listening. And I know you're going to love this episode of the podcast. Well, Dr. J, I think I met you as Jeremy.
Yes, we did. Yeah.
But I like the ring that Dr. J has to your name. So we met at the Las Vegas Executives Association. Dr. Zaki, my physical therapist, who I have actually done an episode on the podcast with. I think he's just a wizard, and I don't think physical therapy does him justice. So if you ever get hurt, I highly recommend him. He's wonderful.
Absolutely.
But I had a chance to get up and kind of speak and tell my story, and I hope it resonated.
We loved it.
Yeah, it was fun to be able to talk with everybody. And afterwards, you and I connected, and I thought what you are doing is fascinating, and I never in my wildest dreams would have started to conceptualize what it is that you do and like why it's important and why this is even an issue. But you really got my attention because I bet I'm a good candidate. I would think.
Is that we're going to go through diagnosing Miesha Tate's, craniofacial?
Why not? Yeah. Well, let's talk about what it is that you do, and then how do you decide if somebody is a good candidate? I mean, do you use it simple as just looking in their mouth?
Yeah, it's interesting because if you would have told me that I would be practicing orthodontics and dentofacial orthopedics the way that I do today, I would have told you you're crazy. I was like, no way. So, when I was a kid, I wanted to become an orthodontist, and I had the very traditional concept of orthodontics. And at the time, that was basically braces. That's what orthodontists did. But a lot of people don't know our title actually is orthodontist and dentofacial orthopedist.
Hmm.
And as I've matured in my practice, I've leaned a little bit more into that dentofacial orthopedic side. And the reason for that, it wasn't that I had some overt interest in that or that I just really was always drawn to that, nothing like that. It's just as I continue to learn about craniofacial development and the influence we have as dentofacial orthopedists, how we can mold and shape the bones in kids and now change the bones in adults as well. It was fascinating, and not enough people were talking about it. And so, then you just start to dive deeper, dive deeper, dive deeper, and you start to realize, the depths of the physiology and where dentistry and orthodontics meets medicine, and the ENTs, the sleep physicians, the pulmonologists. You start networking with people, and before you know it, it's like you've accumulated so much information, and then it starts to come together, and it's like, wow, there's a vast number of people out there who just don't have this information. They don't know, and they're suffering every day with a whole variety of symptoms. And so it's like,
Yeah,
well,
what
what
are
can I
those
do?
symptoms? What are
Yeah.
they?
So, in kids, a lot of time, so if we back it up to its most simple state, I mean, we're basically talking about breathing problems. Okay. So breathing problems in general, meaning,
I'd raise my hand right
yeah,
now.
yeah,
Me.
exactly. Yes. Yeah. And traditionally it's like these stem from mouth breathing, essentially.
Mhm.
Is the root of is the root of what we're getting at. So when we're mouth breathing, the air bypasses the nose completely. So we are designed to be nasal breathers, as are most animals, and the nose plays a lot of important roles. And when that is skipped or bypassed, all of those things start to wreak havoc. So, for instance, one example would be allergies. So it's not that breathing through your nose makes you less allergic than breathing through your mouth, but the response to the allergies that you have is much less if you
Mm.
breathe those allergens in through the nose, because up to 80% of those allergens are going to be captured by the mucus and dealt with the way Mother Nature intended, rather than 100% of them going directly into your lungs, having to be
Oh.
dealt with the immune system. And so that's one example. It ties into asthma as well. But I would say probably the number one thing that patients are trying to improve when they come see me for airway specific reasons is their sleep. So they're not sleeping well, they're not getting REM sleep, they're not getting deep sleep. In kids, they're snoring, they're waking up at night, they're bedwetting at later ages, grinding their teeth. All of these things are symptoms that people are dealing with.
Wait, why is grinding your teeth? My daughter grinds her teeth a lot and she snores a bit. And she's 7. I didn't think that, kids snore.
Yeah, and that's the thing, is that a lot of parents think snoring is completely normal. And if you've just had a trip to
I
Disneyland
thought it
and
was like normal for like old people, but I didn't think it was like normal for kids.
chronic snoring in kids especially is not normal, and it's a red flag. And so, does it mean they have overt sleep apnea? No. You have to have a diagnosis and a test for that. But are they probably somewhere on the sleep disordered breathing spectrum? Yes. Are the oxygen levels probably affected to some extent? Could it be
I
affecting
worry
their
about that.
performance? Could it be
Mhm.
affecting their mood? It could be.
Yeah,
And so,
ability to learn, their
100%, yeah.
brain.
So
Yeah.
so when it gets to the root of it, it's like when we breathe, that's how we get oxygen. Oxygen fuels every cell in our body. And so if the method that we get oxygen is diminished in any way, whether it's in our sleep or throughout the daytime, then we're going to have some effects. And again, it's on a continuum of how much effect that you'll have. But snoring in kids, that is a sign that, hey, well, let's look and see why this is happening. Are they snoring because they have inflammation from allergies? Are they snoring because they have large tonsils and adenoids? Are they snoring because they have a small upper jaw and the soft palate is constricted and long? There's lots of different reasons that can happen, but until we dig into diagnosing and figuring out what's the
Hmm.
root cause, we have to start there.
Okay, so when you are diagnosing someone, what does that look like? What's
Yeah.
your first steps to that?
Yeah, so really the first steps is a questionnaire and a three-dimensional image. So the three-dimensional imaging is probably the biggest game changer as it relates to our ability to start to narrow down and pinpoint where these issues might be arising from. Because before we had only two-dimensional image, it was hard to visualize anything in 3 dimensions. So if you wanted to see the tonsils and adenoids in detail, you had to go to the ENT. They had to
Are the
sometimes.
adenoids the things that sit up in your sinuses that
Yeah.
can cover? Is
Yeah,
that
so
what
the
an adenoid
adenoids, they sit basically, if you can imagine, kind of like behind the soft palate and the uvula, which is that little hangy thing
Mm-hmm.
in the back of your mouth. They sit behind that and a
Okay.
little bit higher, basically right where the nose meets the throat.
Okay.
And so it's actually very close to the area where your ears drain into the back of your throat. And that's why a lot of kids with adenoids that get ear
Mm.
infections, those adenoids swell up, they get big, they cover out what's called the eustachian tube. They cover that tube up. And so now the ears can't drain properly and they're getting ear infections. And that's another, things that now they go to the ENT and get ear tubes. Well, it might just be the adenoids. But
What are the adenoids responsible for?
yeah, so the adenoids and the tonsils, they're part of the lymphatic system. So basically, those are two big centers that deal with your immune system. So things like allergies, things like bacteria, things that the nose usually captures, again, 50 to 80% of, all of that's being sent to the lungs. When it gets captured in the lungs, the immune system as a whole has to deal with it. And so all those cells have to be generated. So these centers, the adenoids and the tonsils, they fire up, fire up, fire up. And then we see these tissues start to swell, and eventually they can swell enough that they become obstructive. And on the adenoids, the bigger that gets, they can almost completely block off their nasal passageway. So when they breathe in through their nose, it's essentially like a golf ball in the back, and the air can't pass through their nose, and so they mouth breathe. Tonsils are the same way. If they get too large, when the mouth is closed, they come together, and there's no room for the air, so these kids become obligate mouth breathers. And then it's a vicious cycle. It's like, what came first, the chicken or the egg? So you've got the tonsils and adenoids getting bigger, which is restricting airflow, which makes it more difficult to breathe through the nose. So they tend to mouth breathe more, which again makes the tonsils and adenoids bigger. And so one thing that parents should know is that if we can revert to nasal breathing, especially day and night if possible, then we tend to see the tonsils and adenoids in kids shrink over time. So the question becomes like, well, how big is too big, and do we intervene? Do we try nasal breathing first and monitor and see if we can, save these kids having to go through surgery? Or are the tonsils and adenoids so large that they really need to be removed in order to get the airway relief and the ability to breathe through their nose now, so they're not suffering the sleep side effects that are associated with those things?
So that's fascinating to me. What I do with my daughter is I ask her to close her mouth when she goes to sleep, and I'm constantly reminding her about breathing through her nose. And it doesn't seem like it's an easy thing for her, because when I say, hey, I say something like, turn your nose on,
Yeah.
turn your nose on.
Yeah.
Just close your mouth and breathe through it, because she gets focused on projects and she's just mouth breathing the whole time.
Absolutely.
And I think I have been most of my life too. I really didn't become aware of nasal breathing, and not for the reasons you're saying, which really fascinate me again, but because I learned that later in my career as an athlete that there are certain gases that are good for you when you pass through your nasal, not only breathing in, but breathing out. And
Absolutely.
we started focusing on that at the UFC Performance Institute. And I would just say, like, I can't really breathe through my nose, and that would really be a struggle for me, because I just didn't have a good, felt like open passageway.
Right.
Granted, I have had my nose broken many times. So there's that. But still, considering how much improvement I've made since I focused on breathing through my nose, I had just kind of resigned to the fact that I didn't have a good sense of smell. I was convinced of that.
Wow. You just thought it's not for me. Smelling.
Yeah, like I just thought I'd
Some
broken
people
my
are good
nose
at
so many
it.
times, and that I just didn't have a good sense of smell, and
Yeah.
then I didn't have good nasal passageways, and that was it. So it just was what it was. I was just a mouth breather, even though I didn't know that was a term or something that I really paid much attention to. But I do think that this was probably exacerbated by breaking my nose and literally being forced for weeks on end to not be able to breathe through my nose. And then you kind of just become in this new habit.
Absolutely. Well, habit and or the environment changes in those situations. So you touched on something really important. You said there's some chemicals or molecules that's added to the air when you breathe through your nose. So probably one of the most important ones of those is something called nitric oxide.
Yes.
And nitric oxide is super duper important. And when you're breathing through your mouth, you're bypassing that entire system. So nitric oxide is basically Mother Nature's anti-inflammatory. And so it's antibacterial, it's antimicrobial, antiviral. And so when you're breathing that in, it's actively breaking down pathogens, and it's also a vasodilator. And so it helps to increase the oxygenation in the lungs.
Right.
And that's why from an athletic performance standpoint, you tend to have anywhere from 10 to 18% more oxygen per breath, essentially, when you're breathing through your nose than when you're forced to breathe through your mouth. So obviously, if you breathe through your mouth, you're going to get a higher volume of air in. But that volume of air is not going to be as efficient per gallon, right? So your oxygen per gallon decreases when you're mouth breathing, whereas when you're nasal breathing effectively, you're actually getting more oxygen per breath.
It's more efficient.
Absolutely. Yeah, on the inhale and on the exhale, as you remember, because I remember as a kid, it was always, breathe in through your nose and out through your mouth. Exactly. But really, it's breathe in and out through your nose. When you breathe out through your nose, you are pushing the air out of a smaller hole, essentially, which creates a higher pressure in the lungs. The gas mediation between oxygen and carbon dioxide is in part mediated by pressure. So when that pressure is slightly higher, for lack of a better description, it's kind of pushing more oxygen into the alveoli, into the blood, which then allows, again, a higher degree of oxygenation. So to your point, you break your nose. Well, now all of a sudden you're an obligate mouth breather because you can't breathe through your nose because it's plugged full of everything, right? And so now you're mouth breathing, you're bypassing that entire system, and now you take off everything, and all of a sudden it's like, take a breath in, and it's like, well, that's kind of not as easy as it used to be, right?
Right. But so I imagine the system kind of atrophies in a way.
Well,
right?
atrophies, and you're not getting that protective benefit. So if you don't have Mother Nature's afrin, you're going to be experiencing a higher level of inflammation due to just normal allergies, congestion. I used to wake up every single morning congested, and I just thought it was normal. Yeah, I just thought it was normal. I thought it was, that's just how it's going to be. Not to get onto too controversial of a topic, and I don't want to mention it and just go away from it, but something like lip taping in adults, can be very beneficial because if your anatomy can tolerate it, because it helps you to breathe through your nose during the night. I started doing that almost a decade ago, and I wake up not congested essentially every morning.
Yeah.
And it was something I never would have guessed was even possible.
Well, you gave me some of those. They were really interesting. I liked it. I tried that. And I don't, what were they? What are they?
So Myotape was the brand that I recommend the most, and I don't have any connection or ties to them, but if we want to take a little aside and talk about lip taping, this is where like a lot of people tune out. They're like, oh, taping lips, it's crazy. But really, if you understand it, it's not crazy at all. You do have to be careful.
It's a tool.
Yeah, exactly. It's a tool, and there are safety considerations and things like that. But these are all things that can be learned, and you can talk to your doctor about it. We talk to patients about it all the time. The tape I recommend does not seal off the lips. And so basically what it does is if the facial muscles are relaxed like they are in deep sleep, then the mouth will stay closed. If you open your mouth, you can do that. You can cause your mouth to open if you intentionally open it. You can take a drink, you can talk, things like that. And so especially in the kids who are doing the lip taping, that's the tape I recommend. But in adults, it's the same one I recommend as well, because it's not necessary to seal off the lips completely. You basically just want to make sure that when you get into those deeper sleep cycles, that your mouth doesn't hang open and cause you to mouth breathe all night.
I would like to say something that I figured out when I was really exploring how I could nasal breathe more and even during sleep. And I did not do mouth taping when I was teaching myself, or figuring out, exploring how to do this. But for me, it's not as simple as just closing my mouth. There's a technique to it that I found. It's like almost if you swallow, like you're trying to get all the spit out of your mouth so that you create this seal. So as you swallow, you keep it at the top of that swallow. You don't let your tongue lose the suction in your mouth. You kind of want that seal when you start to fall asleep so that you don't your mouth doesn't just fall open and your lips come up, apart and then you're breathing through your mouth. Or even if your lips still stay together somehow, which I think sometimes happens with my daughter, I don't think she understands how to make the seal, is that the tongue is still loose in the mouth and it falls into the back of her throat even when her mouth is closed, and that's not helpful either. So I do think is that correct? Is there a little bit of a technique to it?
Yeah, 100%. So there's a whole discipline dedicated to exactly what you're talking about. It's called myofunctional therapy. And essentially that's like physical therapy for your mouth and tongue. And what you do is you train the tongue where to go, and you also do exercises that strengthen the posterior tongue muscles. And some people say, well, what does that have to do with sleep? Because as soon as you fall asleep, your tongue's just going to fall back anyway. But there's lots of good clinical research that show over a long period of time, if you're doing these types of exercises, you will develop a more forward resting tongue posture, even when you're sleeping. And for patients with apnea, it can reduce the AHI, which is the apnea-hypopnea index. Basically, it rates the severity of your sleep apnea. Can reduce it in 50% with compliant patients with myofunctional therapy. And so that's something that, again, just people don't even know what a myofunctional therapist is. No idea what they do.
Yeah, I didn't.
But there's a lot of adjuncts. Something else you touched on briefly, you said, okay, well, when I seal the lips, it makes it easier to breathe through their nose. So they actually have FDA-approved sleep apnea treatment devices that do that exact same thing. So there's something called INAP, I-N-A-P. And basically, it's a little mouthpiece, and it has suction, and you put it on the top of your tongue, and it basically sucks your tongue to the roof of your mouth and seals off the soft palate in the back, and it holds it there while you sleep. And so patients who are trying to get off of CPAP, Sometimes we'll try something like this in order to keep their tongue forward if they continually find themselves, with their tongue falling back in their mouth. So we use a lot of these tools diagnostically to understand, sleep apnea is not just, a one size fits all. There's so many nuances and different types. People experience sleep apnea for different reasons. AHI just tells you the severity of the apnea. It tells you no idea. It tells you nothing about where the apnea is coming from. Is it nasal? Is it oropharyngeal? Is it central? Does your brain just turn off? Like, there's so many different things that can be happening with apnea. A lot of the treatment tools are actually what we use to kind of fine tune and figure out, okay, well, if this, non-invasive reversible treatment tool worked for you, well, then it's likely that this, either surgical approach or what we do, non-surgical approach, may work for you as well.
Yeah, really, really interesting. How about what about the general shape of the mouth is it that makes that difficult for some people to do? Are there some people who would have a more difficult time creating that seal, moving their tongue to the front of their mouth and kind of creating that suction so that it doesn't fall into the back part of the mouth? Tongue ties, I think you've talked about that a little bit before too.
Yeah, 100%, right? So tongue ties can be tricky. And again, that's one of those things where you mention it and you really can't do it justice without doing a deep dive. There's an entire book on tongue ties. I think it's called Tongue Tied. And it goes into a lot of the nuance. And if you think you may have that or you're curious about it, pick it up and read it. It goes through a lot of the research as well. But essentially, if the tongue doesn't have enough mobility to get to the roof of the mouth, it's not going to suction. It's not going to seal. And so myofunctional therapy is one thing that can, even without releasing the tongue tie, can help you to basically stretch everything, stretch the tongue, allow it to get to the roof of the mouth better. Some tongue ties are so severe that no amount of myofunctional therapy is going to help you to create that seal. And those are the tongue ties that, benefit most from being released. But the opposite end of the spectrum is true as well. Like, if you look at your tongue and you're like, oh, I'm tied. Well, if you're not doing the myofunctional therapy, just going and getting your tongue tie cut may not benefit you at all. And certainly it can even get worse if it scars up and you're not aware of that potential and doing the stretches that are recommended afterwards, all those things. So I'm not a tongue tie specialist. I don't treat it, but I work with a lot of practitioners who are. And when that's an issue, again, if it's diagnosed properly and you can get it corrected at an appropriate age and you can follow through with the adjunctive therapy, specifically the myofunctional therapy before and after, you can have a meaningful change in your ability to keep your tongue forward more naturally and hopefully avoid having to go a more medical route with managing your sleep or breathing or whatever it is you're dealing with.
Yeah. Well, I will say, since I focused on it, which I touched on earlier, but just to kind of button that up, I can breathe through my nose now with nothing else than just putting focus on there and doing a couple little things that I could just do in my day-to-day, making sure, putting effort into breathing through my nose. And then it feels as though the passageways have sort of opened up or they're cleared out, and there's nothing else that I have done. I don't use like nasal sprays on the regular, like every once in a while, maybe a Flonase, but I don't use any, what's the other one? The
Afrin.
Afrin.
The short acting, which are terrible for long-term use.
Right.
So,
Yeah. I'm definitely aware of, the long-term use and the addiction and all those kinds of things that your sinuses can kind of get stuck on
rebound inflammation. Yeah, you end up worse than you started if you're using them too much.
Yeah.
So yeah, can they get you through a really rough patch? Yeah, sure. That's kind of what they were designed to do. But patients who find themselves or people who find themselves having to use it all the time, it can make their symptoms worse over time. So you're wise to be looking into, well, how can I use my body's own physiology and chemistry to help what's going on, because that's a fix that doesn't require any external medicine, right? You can do it on your own, right? Just learn how to breathe through your nose. If there's anatomical challenges to that, possibly addressing those anatomical challenges, that's what I do in my practice. And then getting to the point where that's sustainable.
Yeah. Did you have you had that similar? So like now when I wake up in the mornings, granted I've had a successful night of not breathing through my mouth at night. I wake up and I'm relatively clear. I don't have like a bunch of junk that's just been, just I feels like I have to clear my nose when I don't. It's a very, very stark difference between the
body
mornings.
did what it was supposed to do, right?
Right.
Kind of magic. It's like, great. Yeah, this is kind of how things are supposed to work, right? I don't think we were designed to have a bunch of junk in our nasal passageways and congestions and all this stuff to clear. If the body's doing its job, it's clearing that at night. So to your point, what my personal journey with all of this, yes. So I have what's called a jaw size discrepancy, meaning that like if we go back and we look at skulls 500 years ago, by and large, the upper jaw was about 3 to 5 millimeters wider than the lower jaw. And you look at these prehistoric skulls and you see there's no crowding on the teeth. They had room for their wisdom teeth, sometimes spacing between the teeth. They tended to nasal breathe continually. They just didn't deal with a lot of the issues that we're dealing with now. So when I measure my own jaws out, there's what's called a jaw size discrepancy, meaning that my upper jaw is not 3 to 5 millimeters wider than my lower jaw. Now, when I was treated, I mean, I love my orthodontist. I love my smile. I feel like he did a good job getting my bite idealized to the best of their ability with the knowledge that we had at the time.
Yeah, your teeth look great.
Thank you. But again, like, I mean, if I could go back in time when I was 7 years old and have a maxillary expander, make my jaw wider, make my upper jaw 3 to 5 millimeters wider than my lower jaw, I would in a heartbeat. Because we fast forward all these years later, and I have mild REM-related sleep apnea. For years I woke up congested because I was mouth breathing at night, chapped lips, dry mouth, like all the symptoms, snoring. All of these things were going on for years, and I just didn't know that there was anything I could do about it. And it's like, okay, well, it's mild, so I don't want to go on a CPAP and do all that.
Yeah.
But now with everything that I've learned, so one, I'm actually in the process of getting started with my own non-surgical skeletal expansion, which is, again, what I do for a lot of patients in my practice. But until I do that, I lip tape every night. I have what's called a mandibular advancing appliance. So that's basically an appliance that moves the lower jaw forward when I sleep, and then I use a nasal dilator so that my nasal passageways are open.
You mean like one of those stickers that you put on your nose?
Yeah, so it's like a breathe right strip. My favorite
Okay.
one is called Intake. Came out maybe a decade or so ago. And it has two little metal dots that you put on the side of your nose. And the cool thing about it is that you can adjust exactly where those dots go. And then there's a rigid bar, and they make different sizes of those bars. And when you put the bar on, the metal from the dots sucks to the magnet on the bar, and then it opens up. So you can open it up the exact amount that you need.
So are they stickers? The little.
So yes, the metal dots are stickers, and then the bar that has the magnets in it is rigid. And
Single use?
So the metal bar is multiple use.
Yeah.
And the little magnet part is single use. Yeah.
Okay.
Or I'm sorry, the little metal part. It's a little
Yeah.
metal dot, little metal circle, and that's single use.
Cool.
Yeah, so you replace those. And so it basically allows you to dial in exactly where your constriction is. And so you can open that up. And so now it's like, I can breathe through my nose easily. My lower jaw's forward. So when my lower jaw's forward, it takes the tongue with it. So I'm not snoring. And I have lip tape that allows me to still talk. So like, when I look like an alien with all this stuff on at night, I can at least still have a conversation with the wife or grab a drink of water, whatever it might be.
So you talked about the symptoms that you may have if you are a mouth breather, or you potentially could be a candidate of this kind of, what is it, a therapy? Is that what you call it?
Maxillary expansion, it's a treatment. It's a procedure of some type, right? And so like when we expand the jaws of, let's just say, a 5, 6, 7, 8-year-old, the jaws are very moldable, flexible, and the connections of the upper jaw to the skull are also very moldable and flexible. So all we do is we place an expander on the teeth, and most patients have probably seen or heard of these. And the ones that have heard like horror stories about these is usually when they had them a little late, 13, 14, sometimes even 15. But when you're younger, the expander goes on the teeth. The teeth have roots. The roots are in the bone. The roots are solid at that age. The bone is soft at that age. So you apply a force with the expander connected to the teeth. The teeth roots push on the bone, and the bone widens. And then in the middle, where the two halves of the upper jaw separate, new bone fills in. And when you complete that process, you can look on a 3-dimensional x-ray before and after, and you can actually measure and see the difference in the width of the upper jaw after that process is complete. So as you age, that process does become more and more difficult. And up until about a decade ago, we never thought it was possible to do that type of expansion in an adult or non-growing patient. So once the patient finished growing, basically, we all believed that the two halves of the maxilla were essentially fused together, and they weren't going to open up again unless you did some type of surgery. So for centuries, that's what they were doing. They were just doing jaw surgery. If they needed that upper jaw wider, they would go to the OR. The surgeon would literally cut the jaw off of the skull and then crack it down the middle, pull it apart, and then rigidly screw it into place, and it would be wider that way. So now what we do in non-growing patients is we use temporary mini implants. They're called TADs, so temporary anchorage devices. And we use those temporary mini implant devices. They actually do screw into the bone of the upper jaw. Of course, you're numb when that happens, but it's not in the OR. This is a local anesthetic. You're awake the whole time. So that allows these expanders, instead of being connected to the teeth, which are not strong enough to support adult expansion, they're connected to the bone itself. And then we couple that with different turning protocols. So with our expansion in kids, we always just turned it forward, like 1 turn a day, 2 turns a day, no big deal. Kids tolerate that great. It expands great. Well, you try to do the same thing in an adult, and that turning rate is just far too fast for the rest of the skeleton to adapt to. And so when these procedures first came out, there was a lot of complications and people were turning too fast and they were having asymmetric expansion and there was a lot of problems that were happening.
Painful? Is it painful?
Yeah, it was. Yeah, if you turn too fast, absolutely. Yeah, it can be painful, like so much pressure. So now what we're learning, and we're kind of coming full circle because, as we develop, like what is the best way to expand an adult upper jaw? Well, if you start with the result, well, then you can work backwards to figure out how to get there. So the best result of an adult expansion would be one that perfectly mimics an adult that grew normally. So if you look at an adult that has an upper jaw that's 3 to 5 millimeters wider than their lower jaw, they just got it naturally. Well, I want my adult expansion to look as close to that result as possible. Well, how does that happen? You can't just expand the upper jaw in isolation. The upper jaw is connected to the entire midface. It's connected to the cheekbones. It's connected to the back part of the skull as well. And so all of that has to expand together. And so that's where we get into what we call these dynamic turning protocols with adults. So instead of just turning and cranking the expander open one direction and hoping that everything else just, bends and follows along, now we're doing exercises with the expansion where we're kind of doing what we call stretching turns. So we're kind of pushing a little bit, allowing the body to mold, then we're closing, then we're pushing, then we're closing, then we're pushing, and we're closing. And what our goal is we're trying to get all of the connections of the skull to open up a little bit, to loosen up a little bit, just like they are when you're younger. And if we can make all these connections loosen up a little bit, now when we expand, we're going to get as close of an expansion pattern to natural growth as possible. And it's going to be more comfortable and more predictable. And the chances of complications are going to go way down because the process is going to most closely mimic what natural growth would have done.
That is so interesting. How long does a process like this typically take with an adult, let's say 30 plus?
Yeah. So just to compare it with kids, they're usually turning for a month-ish, and then the expander stays on for 3 months-ish. So the whole process can be done in about 4 months total. In adults, you may be turning for 2, 3, sometimes even 4 months, depending on how big the discrepancy is, because of the dynamic turning that's required and because the rate has to be much slower compared to kids. And then once the turns are done, you're going to keep the expander on typically for about 5 months if you want the least amount of chance possible of things relapsing and the bones moving back together. So that process can easily take, I tell patients, usually about 9 months, plan on about 9 months. And sometimes it can be a little shorter, a little bit longer, but it certainly takes, at least double what it would in a child to get through that entire process.
And then why does expanding the jaw help with so many of the issues that you were talking about? What does that actually do?
Yeah, so the biggest place that the expansion of the upper jaw acts on is the nasal cavity itself. So when you look at a human skull, the roof of the palate or the maxilla bone itself, so it's the top of the mouth, it's also the floor of the nasal cavity. It is the exact same bone. So when you are widening the maxilla, you are by default widening the nasal cavity because that is the floor of the nasal cavity. And so that entire volume increases. So now all of a sudden, like everything from the external, like where the air goes in the nose initially, to the internal valves, to the entire, where the turbinates are, everything opens up and we decrease nasal resistance, meaning we allow more air to go in through the nose. Now that can do a couple of things. If there's constrictions that you can see on an x-ray, then you can be very confident that when we expand, that's going to help your breathing, at least your nasal breathing. If there's no constrictions, well, it may not help as much. And that's where the diagnosis comes in. I do have patients that come to me and they say, hey, I want you to expand my jaw. I have sleep apnea. And we look through their imaging and their upper jaw is pretty close to normal size. The nasal anatomy is pretty close to normal. No, I'm not going to expand you because it doesn't make any sense, right? The likelihood of that fixing your problems is very low. But if you do have constrictions within the nasal cavity and you do have an upper jaw that's small, then as you eliminate those constrictions, it allows more air to come through. And some of the newer studies they're doing is actually, comes from the computational fluid dynamic world. And what they show is these constrictions further up in the nasal passageway can actually cause turbulence further down in the airway and cause that airway to become more collapsible. And so I would say the number one benefit is it allows you to reduce these restrictions within the nasal passageway. Some patients come in, it's like, I can never breathe through the left side of my nose, or I can never breathe through my nose, period. Like, I just can't. Like, I just,
Yeah,
it's just, exactly.
that was basically my story. I just thought like, I was like, yeah, I just don't breathe through my
Right.
nose.
Well, and I love what you did, because again, that's the most conservative way. If you can get long-term relief just by utilizing your own body's physiology, and you don't need to make an anatomy change, that's great. Like, if I can get a patient sleeping and breathing through their nose, and all their symptoms go away, and they're happy with their smile and their bite's fine, like, why would I expand them? I mean, that would be just an unnecessary extra procedure that they don't need if they've tried these other things. But so many
Right.
patients just don't even know that there are other options. They just think, we always want to fix things with medicine, with surgery, with whatever it is, And again, I do procedures, right? I do expansion. That's what I do. But I spend a lot of my time just helping patients understand why they don't need my procedures. And so I have a book coming out soon. It's called Airway-Focused, and a lot of this goes into the details of why you might not need my services, and things that you should actually look at before you go down the rabbit hole of either maxillary expansion or even more invasive double jaw surgery, where they actually bring the upper and the lower jaw forward in the OR.
So that's available for pre-sale right now.
It's available for pre-sale. Yes, it is. Yeah.
Where are people looking for that?
It's on Amazon.
Amazon.
Yep.
Okay,
So
great.
Airway-Focused, yeah.
That's exciting. I'm
Yeah,
excited to read it.
Yes. It's been a labor of love. Again, if you would have told me I was going to write a book one day, I would have said, no, that's not me. I don't even like, I never liked English in high school.
I want to dive into that a little bit. I want to uncover your personal story a little bit, because you said you knew from a young age that you wanted to work in orthodontics, but there's also some things that you were just like, I never expected.
Right.
So kind of walk me a little bit through that journey, and where was that turning point that you realized that there is something that's not an unmet need that you could fill those shoes? And are there a lot of people doing? I mean, is this a new I've never heard of this.
Yeah, most
there a lot of
people
people doing
haven't. Yeah.
this?
So for me, it was like, when I got my own braces, like, it was a time in my life. My parents had gotten divorced like a little bit before then, so life was kind of like, there was a lot going on anyway. My canines were coming in. I didn't like my smile. I didn't like to smile in front of people.
Did you have really crooked teeth?
Yes,
Upper and lower?
Well, and mostly upper, because my upper teeth were so crowded, and my canines had no room, so they were sticking out like fangs, and I just hated the way that it looked. And so I begged my parents for braces, and they both went in and they got me braces, and that transformation process was just so fascinating to me. And when I was done, I love my smile. I still love my smile. And so that for me was like, man, I can actually do this for people and, have a good career in doing it. So that's when I didn't even know how to spell orthodontist. I think I have a 7th grade paper where I spelt it wrong. And I was like, oh, I want to be orthodontist. Anyway, so that was always my goal. I was like, I want to give that confidence to people. I want to be able to provide, that kind of influence in their life. And so that was my goal all the way through until I even got into orthodontic training and came out of school. So none of this stuff is well, most residencies don't teach these things. They are basically too new, and typically the residency programs fall anywhere from 20 to 50 years behind the most current and up-to-date research, because essentially they wait until there's 100 peer-reviewed long-term studies on anything before they, will actually accept it and teach it, if that makes sense. So to many programs' credit, there are a few out there that are actually teaching these concepts and procedures. Stanford is a huge program that does a lot of sleep medicine, and there's some other programs across the country that do focus on sleep medicine in addition to orthodontics. But for me, the journey started once I was out into private practice. And when we first got involved in three-dimensional imaging, we started to see things that we had never seen before. And my personality, I always have questions. So I was like the kid that my mom was like, here, don't ask them that. Don't, you know what I mean? Like, I was always asking questions about everything. I just
I've always been so inquisitive too. My doctor's probably annoyed. It gets so annoyed because I always want to know the why of everything.
Yes. And so all of a sudden, like, we have this data that we're seeing in our office, and I'm like, there's so many whys. So I just started to take courses, and it's like, okay, well, I take a course, like, wow, I've never heard any of that before. And like, that's interesting. So then we grab some books, like, oh, well, let's read. Well, I've never heard any of that before. And before I know it, I mean, it's just like multiple courses, continuing education, networking with other doctors, reading more books, looking at the literature. One of the things I love about AI is that we can do deep dive in literature more efficiently than we've ever been able to before. So it's like, you don't have to trust what AI is saying. They're going to give you the exact sources of the information, so you can actually go to the published data and look at and see, like, what is going on, what is being published this year, last month, a year ago. And you take that information, and really, once you start to cross the bridge between medicine and dentistry, things start to connect, the dots start to connect, and it's like you see more and more and more. And then you start to treat patients, and you have patients that have severe sleep apnea or moderate sleep apnea. And all of a sudden, they're able to breathe through their nose. And now all of a sudden they don't have apnea. They're able to get off their CPAP or whatever all these problems that they're dealing with. And it's like, wow, this is actually really, really powerful. This is something, again, that I just never imagined was even possible. I would say one thing where we're still lacking is there's still this big disconnect between medicine and dentistry. And so, like, as an orthodontist, I work very closely with ENTs, pediatric pulmonologists, sleep doctors, sometimes pediatricians. That's uncommon in orthodontics. Like, most orthodontists never even talk to those specialists. I mean, it's just two different worlds. And insurance has done
It's
a
kind of a
yeah,
problem in the entire medical
yeah,
world.
it
If
really is.
looking at it from my outside perspective, it's like I don't necessarily understand why there isn't cross communication. Well, I do, because it's not convenient, and it probably costs more time, and time is money, and it's just kind of like, this is my area where I operate, but then it puts that on the client to try to connect all the dots of like this and so many of the things that you just talked about, ear, nose, throat. What is the issue? Like, how are they going to be guided to actually being successful? No, you don't need a jaw expansion, these kinds of things. I think it's so helpful and so underrated for the cross communication across platforms to really help people get the help that they need.
100%. Yeah. And again, this is where medicine and dentistry really do cross over, because I mean, a lot of times we're dealing with medical issues. We're dealing with allergies. We're dealing with asthma. We're dealing with sleep apnea. All of these are medical diagnoses, medical terminologies, but it's a quote unquote dental fix. Now, really, it is a medical fix, but there's no medical specialists that are doing this, right? And so as dentofacial orthopedists, we're tasked with helping these patients to idealize their anatomy and get their jaws to ideal position. But the insurance companies say, like, well, you're dental, so that's optional. And the medical is like, oh, well, if you need this, then just go get your tonsils and adenoids out, or let me give you these medications or whatever. And so there's this disconnect and this crossover that's just not happening well enough. Ideally, when expansion is done for medical reasons, I mean, it really is a medical thing. So that should be kind of in that wheelhouse, but the division is just not set up that way. Our system's not set up that way.
Do you see an improvement in people's allergies typically? I mean, I know you said that earlier, but like, is that something that you've really noticed in your practice, that people improve that?
Yeah, we really have to get into the nuance here, but the allergy symptoms, yes.
Yes.
100% the allergy symptoms.
Symptoms, there
And
you
again,
go.
And it's not the magic of me doing an expander. It's like, oh, the expander fixed your allergies. No.
No.
The expander allowed you to breathe through your nose, and your body limited the effect, the unnatural effect, the exacerbated effect of allergies combined with mouth breathing. So it didn't make you less allergic to anything that you may be allergic to, but it reduced your response to those allergies by up to 80%. And so, the allergies are only a problem because that's what you are experiencing. I mean, if someone just told you, yeah, your body's reacting to something, but you didn't feel it, well, who cares, right? I mean, it's just going to kind of like go through, and it's not going to be a big deal. But when you have these severe or over-exaggerated responses to those allergies, that's when we're miserable. I mean, our eyes get red, our our noses are running, we're all stuffy. That's where it becomes a problem. And so breathing through your nose allows those allergens to be captured. They capture in the mucus, they go into the gut. The gut is designed to package those up nicely and get rid of them, and it doesn't task the immune system. That's where all the antibodies get fired off, at which point, that's when you start to feel not so great.
So fascinating. I didn't conceptualize that before, so thank you for breaking that down. That's really good, especially because Johnny, my fiance, has severe allergies. Sometimes he has to get that allergy shot once a year.
Yeah.
But obviously I sleep next to him. I know that he often mouth breathes at night, and I can't be the one to tell him, so I'll just have to tell him to listen to this episode of the podcast.
Just listen to the podcast.
Oh my goodness. Okay, I had another quick question. Is teeth, like the indentation of like your teeth on the sides of your tongue, is that a common way to kind of know that maybe
it's a red flag, right?
It's a red flag.
So just like snoring is a red flag, I mean, if you have indentations from your teeth onto your tongue and you're seeing those on the sides of the tongue, again, it's a red flag. It may mean that either your teeth and or jaws are too small and it's crimping. It may mean that your teeth are tipped inward or that your tongue is too big. It's not natural, right? So normally the tongue would be able to fit with space inside the oral cavity. And so if we're seeing those things, that may be a sign that there's not enough room. And so again, we want to start doing some more digging and getting to the root of, what may be the problem, what's causing this.
Speaking of digging, why do you think that this is becoming a more chronic issue? Like, why 500 years ago? I mean, you and I have talked over this. You know, we stopped and had some coffee, and you had some really interesting points and thoughts that I would love for you to share with the audience.
Yeah, so this is where it gets really, really fascinating. And, for years, and mostly what I was taught in residency is like from a scientific standpoint and from a, an institutional educational standpoint, people love to rely on genetics. They love to explain everything by genetics.
Mm-hmm.
And when you look at most of the bones and the growth and the things that happen within our body, they have very, very close ties to genetics. And you can actually link those things together. For instance, if my mom's 4'11" and my dad's 5'1", I'm probably not going to be, 6'3", right? I mean, and there's a strong genetic correlation that can indicate that. Now, the interesting thing about the maxilla specifically is it seems to be less determined by your genetic potential and more determined by the environment in which the jaw is developing. And the reason we know that is because within a couple generations of our modern diet changing, we started to see these changes in jaw size. And you can go back to the data of these
So
skulls.
this is kind of an adaptation.
Exactly. It's an and not so much in a good way, right? It's essentially like kind of a use it or lose it thing. And so there's no way that the genetics can change that quickly. They're not going to change in 2 generations. So there has to be other things that are causing that. And that's where the debate comes in. It's like, well, what other things are there? Well, there's a lot of other things, right? So the diet, the food that we eat, the chewing muscles, what's required of those, breastfeeding versus bottle feeding, nasal breathing, allergies. Like, so all of these things play a role in how our jaw develops. And so as we think about that, I don't know that anybody knows the exact answer on which of these factors is the biggest factor, which one matters the most, which one should we spend most of our time thinking about. But the more I've learned about adult maxillary expansion and seeing these changes, when we are able to make the connections of the upper jaw soft, mobile, moldable again, we are able to expand so much more. And so when I think about this and I look at, thinking about kids, yes, physiologically, those connections are looser, but are they as loose as they were when we had kids, eating roots, carrots, hard foods, chewing on bones? Like those forces of occlusion, when you think about that, when you bite down, yes, there's force going to the teeth. Well, the teeth have roots. The roots are connected to the upper jaw, and the upper jaw is connected to the rest of the skull. So all of those, what we call sutures or circummaxillary sutures, those connections of the upper jawbone to the rest of the skull, there's force on those. There's pressure on those. They're actively being acted upon. And so when we look at that, and there have been some studies that have looked at that. For instance, when they feed mice harder foods versus softer foods, they can actually measure a difference in those jaw sizes in as little as 2 weeks in
And
grown
not just the
mice.
muscles, but like the bones.
The actual bones themselves, but yes, in the muscles as well. A lot of the research has been demonstrating on the muscles because it's easier to quantify, and you can measure it in a shorter time period. But yes, in the actual bones themselves. Another study, landmark study that was done, they took monkeys, and I doubt it would get passed today, but they actually sewed the monkeys' noses shut so that they had to be obligate mouth breathers. And these monkeys developed dental crowding, and they developed smaller upper jaws. And all of the symptoms that we associate with mouth breathing, these monkeys were experiencing as well. And so, you have the nasal breathing versus the mouth breathing. You have, this functional theory is like, well, if we can get kids, chewing on harder things, and I don't know what the answer is. I mean, I don't know how feasible it is. When, prehistorically, we were chewing 2 to 4 hours per day. And you think about that, is that really possible or feasible? Now we chew an average of about, maybe 30 to 45 minutes if you add up all the meals. It's quite a bit less than it used to be. And then in conjunction with quite a bit softer foods than we used to eat. So, maybe the answer is we give all the kids jawline gum and that makes a big difference. Or, the breastfeeding has a big part of it as well. Like, how much does that matter? So all these things play a role. If I had to guess at this point from what I know and what I've seen, I really do think that the occlusion and the forces that we are placing on the jaws, especially in younger kids, probably makes one of the biggest differences. And that just was something that, again, even a decade ago, I would have not guessed. I wouldn't even been able to explain how that would have made a difference at all, truthfully. But when you have the force on those sutures and those sutures loosen up, that's really like, it's basically making something that's normally rigid soft enough. It makes it more like Play-Doh. And so like any of the other forces that there are, whether it's breastfeeding, whether it's keeping your tongue on the roof of your mouth, swallowing properly, nasal breathing, all of those forces are going to have more of an effect on shaping the jaw if the jaw itself is easier to shape. So I view this as like make the jaw itself easier to shape, and then all of those other things that you're doing are going to have more of an effect in improving the jaw shape.
What's jawline gum?
Oh yeah, so
I was
jawline
like,
gum,
there's
yeah,
a
it's kind of
thing?
it's kind
It's
of
not
like a
just
training-
regular gum?
Yeah, exactly. So with the whole looks maxing and everything like that, so you have a lot of especially young men. I mean,
But
so
they want to have
yeah,
the
they want to develop these masters. They want to get like chiseled jawline
Yeah.
and everything. So they'll chew jawline. It's basically gum that's difficult to chew.
Okay.
Right? So they formulate it in a way that it's harder to chew. It's like
Okay.
hard gum
A
essentially.
little bit more of a workout.
Exactly.
Okay. And breastfeeding. Can we talk about that a little bit? That's really was interesting.
Yeah.
What you said, what you had to say over tea that one day.
Yes. So two major influences that breastfeeding has. So it's doing two things. So one, obligate nasal breathing, right? So when you are a baby is breastfeeding, they can't breathe through their mouth. They have to breathe through their nose. And so they're learning how to be obligate nasal breathers. The other thing that they are learning is how to properly swallow. And in my opinion, this may be even more important, because if they don't have that, they are never essentially, I don't want to say forced, but kind of, they're never forced to swallow properly, right? Because with a bottle, all you have to do is hold it up and get any type of suction, and you bite on it, chew on it. You can get milk out a number of ways. With breastfeeding, there's really only
You have to pump, from the front.
it has to undulate and it has to be on the top of the mouth, and so you're training
Yes.
that baby how to use their tongue properly. And so, how long do you have to breastfeed in order to solidify those habits? I don't know. Probably the lactation specialist would be a better person to talk with about that. But at the end of the day, in addition to, creating obligate mouth breathing, and not even to go into any of the other benefits about, breast milk versus formula from a nutritional standpoint, but just from a physiologic standpoint and a functional standpoint, training the babies how to breathe through their nose and also training them how to swallow properly, both of those are going to have an effect on their development and growth over time.
And I think you said something too about like the fullness of like the breast and the mouth potentially. I mean, do you know if these are things that have been studied, or is this a little bit more of like we're kind of like hypothesizing at this point that maybe this has some impact? It would make sense, right?
Yeah, it's super difficult to quantify in a study, right? So I mean, how are you going to do that essentially? So let's just say you have identical twins, genetics are the same. I mean, are you going to breastfeed one and not the other, right? And then you're going to times that by how many people? I mean,
Correct. Yeah.
most of the time we try to do the best thing possible for our kids, and so it is very difficult to quantify. But there's really in today's world, there's not so much debate on if these things have an effect. The question in the debate is how much of an effect do they have, and which ones have the most effect, and where should we spend our time and our energy in interventions? Where should we put our focus? I mean, should we put all of our focus on breastfeeding? Should we put it on myofunctional therapy? Should we put it on chewing? Like what are the things? Should we put it on nasal breathing to reduce allergies? Like, where should we put our time and focus in order to get the healthiest development possible? But to your point, yes, when the breast is in the mouth, the breast is larger than a bottle. So that does create a force that, again, helps to shape the palate. And the more mobile the jaw is, the upper jaw is, the more flexible it is, the more of an effect that's going to have.
Yeah. And the bottles, at least they used to. Now they don't have as much of like the suction. But I remember you mentioning something about that potentially too, about a bottle. How it's kind of pulling the mouth down, so to speak, in a layman's terms, as opposed to like filling the mouth.
Correct. Yeah. So a bottle, you're essentially creating a negative pressure inside the mouth in order to express the milk. Whereas with the breast, the milk is designed to express, but it's not suction so much as it is proper swallowing and undulation. So it's more of a waving motion. The pressure in the mouth does not have to be negative in order for the milk to be expressed. Whereas with the bottle, at least with most designs, you have to create a negative suction force. So again, how much does that negative suction force matter, like that factor specifically? It's really, really hard to ever design a study that would definitively tell you. But the concepts are what's important here, right? We only have control over a certain number of factors as we are trying to raise the healthiest kids possible. And so any of these things that we can identify and say, okay, well, this makes sense. This can help. Let's add this to the things that we do have influence over. Potentially you add enough of those things up, and we can get the best development possible.
Yeah, and there's one more thing I would like to say is I nursed both of my kids for at least a year. Is that it takes them a lot longer.
Right. And that's challenging, especially in today's world, right?
Yeah.
Because it's so much easier to just, pump and grab a bottle, right? And
They
that's where,
finish it very quickly.
yeah. And again, I mean, and again, I think there's benefits to that, and I understand, and that's a real concern, and there's sometimes not a great answer for people.
But what's good about it, though, is that they are nasal breathing for longer because, it takes it takes a lot longer to nurse a child. And oftentimes they want to continue to comfort nurse,
Right.
right? So they want to stay attached. And it makes sense that it is promoting health in a multitude of ways. And I just want to say that I want to encourage all women out there who can breastfeed to fight for that and to just know that you are doing something incredible. Like I want women to feel the value that they bring with doing that, because I understand how difficult it could be. So you're the only person sometimes that can feed your child. Granted, you aren't pumping and someone's feeding with a bottle, which I've done, plenty of. But I want women to truly feel valued in this. And this is what we're uncovering, is some of the value, some of the potential value for the future of your child and their sleeping. Is like, it is going to be inconvenient. It's going to be tough. And there's a high demand on mothers to be in the workforce and to do all the things. But I just want to praise you for a second. If you're doing it, you're awesome.
Keep it up.
Yeah, keep it up and just fight for that, because you're doing so many incredible things for your children, and you deserve like all the praise in the world.
Absolutely.
So like, just don't be quick to give up on it because it's tough. You got to like realize that you can do difficult things. And I know that breastfeeding is one of the more challenging things to do for women. I get it. So if you are listening to this, or if you're even a guy listening to it, like find a way to support
Absolutely.
your make it easier on her. Like, what can you do to help her? Is she working a job? Can you bring the baby during lunch? Can you support her in any way, any shape, any form? Because it's just such a wonderful thing to do. And I think a lot of women want to be able to do it, but some women also feel the pressure and they kind of they give up. And I think I do understand it, but I want women to know the value that they possess in breastfeeding their kids, and that's it. And if you choose not to and you don't want to, and that that's fine, it's okay. But just know, like, you are an extraordinary being to be able to do it, and maybe just fight for it a little bit more.
Absolutely. And hopefully this information is empowering. Hopefully it just gives you
Yeah,
one more,
that's
one
what I
more
want.
exactly, get a cause, a purpose. And again, you get it. People get busy, but and to
Yeah,
your
you're
point,
not just
it
feeding
is
your
teamwork.
baby.
Yeah.
Like, you are performing a miracle.
Yes.
Like, every time that you do that, I mean, I really think it is miraculous. And I
Yes.
think that women deserve all the credit in the world, not only for birthing their children, but for fighting for that ability to sustain their children as well.
Absolutely.
Yeah.
Yes.
So cool. This has been really interesting. I feel like I've learned a ton. Some of it I know we chatted about a little bit before, but you really painted a picture in a way that I feel like was digestible, and I could really understand it from somebody who didn't go to medical school or anything like that. And I find tremendous value in what you're saying, and it comes from an angle that I've never seen sleep addressed. And just recently, for me anyways, I would say the past few years, 4 or so years, addressed from a performance standpoint. And so it wasn't until I started addressing the performance standpoint that I started to realize how much it affected my sleep.
Right.
And then now understanding how much it can affect things potentially like allergies. And now I can start to be more proactive. Like, if my children, potentially could benefit at a younger age, or even if it's something that could still make things easier for me. Because sometimes when I lay down at night, I don't know why this is, but it's like the moment my head hits the pillow, my nose gets congested right away. And
Yeah.
I don't know if there's something I could do to like be more aware, but it's like I'm fighting for that. And sometimes I give up when I go to sleep. I'm like fighting to try to breathe through my nose, and I'll try like 10 different times, and I'm like, I'm just too congested tonight, and I'm exhausted. And
Yeah.
I hate the feeling of stressing out about not feeling like I can breathe when I'm going to sleep. And I want to be able to breathe through my nose, but I'm laying down here and I realize like I'm struggling.
Yeah.
But a lot of times it does clear up for me when, you try a few times, and you're basically, I look at it like you're sending messages to the nose to turn on. Like,
Right.
I need you to do your job right now. So I'm going to continue to force breathe through my nose as I'm reading my book or I'm scrolling my phone, which of course I never do in bed, But I'm fighting with my nose to send the signal to like, wake up. I need you to like do your job through the night, and I need to be able to breathe through that.
Well, it's super intuitive that you would say that because there are actually nose clearing exercises if you search them up online, and essentially that's what they amount to is essentially you're intentional about your breathing. And like for instance, if you're having difficulty breathing out of one side of your nose, you'll close off the side that you are breathing well through, and just kind of like really slow down the breathing and just really, it's going to take you forever, right? If it's congested, it might take you 8 seconds to get a breath in or out. But what happens is you're sending that signal to the body, and you're ingesting that nitric oxide on the
Which
bad
you mentioned
side
is an
specifically, right?
anti-inflammatory.
It's Mother Nature's afferent, so it does take some time. But if you Google nose clearing exercises, there's a number of exercises that you can do. There's also exercises that you can do throughout the day that help you to be less likely to be congested at night. You know, there's different things with pacing, and there's a lot of physiology that goes behind it, breath holding, and then intake of the nitric oxide filled air. So there's a lot that you can do. It's also interesting that you sort of discovered this through more of an athletic performance standpoint. So, you know, whenever I first hear about something, a lot of times I try it out on myself first. And so I started lip taping. I was like, great, you know, I'm waking up not congested. Like, that's cool. So then I start to hear about the benefits of, you know, from a performance standpoint, from an oxygenation standpoint. And, you know, I did 21 and a half years in the Army National Guard. So for a long time, I was taking PT tests twice a year, and we would run 2 miles. And so I had like my normal training regimen down, and you know, I'm not trying to be like the top scoring PT person ever, but I knew what my scores were. I knew what my 2 mile run times were, and they weren't amazing, but I would run, you know, typically about 16 and a half minutes for 2 miles for years. I did nothing else except for start to nasal breathe during my runs, and within 6 months, my times went down 2 minutes. And so for me, I was like, whoa. And it was crazy because like the first 2 weeks of doing that, if you try to exercise with only breathing through your nose, one, I mean, for me, I had to have nasal dilators. So I had to have something artificially opening my nose just so I could get the air in.
Like the one you
Yeah,
mentioned
with
on
the
the
intake strip, or they have other ones called
I've put the one that like that's what I started with when I was sleeping to get my nose open.
Yes.
And then for the most part I'm able to now usually activate that on my own.
Yes, which is great.
I'm glad to know about the exercise though. I'm gonna look into that a little bit more.
Yes,
But,
yeah. The first 2 weeks you'll be miserable because your performance will go way down because you're used
it's
to
an
it.
adaptation.
Exactly, it's an adaptation.
It's like when you're in the gym working out, you get weaker first.
Yes.
And then you get stronger.
100%. So when, you know, nasal breathing, you're like, I can't do anything. I can't do my normal thing. I can't go as long. I can't go as fast. And my resistance, whatever it might be. But then once you get over that hump, your performance will increase dramatically.
Why do you think the performance is increasing dramatically? Like what happens?
So in my opinion, it is that difference, that 10 to 18% difference in oxygenation and training your body to be able to intake that oxygen. So like after I got used to running with nasal breathing only, like if I started to mouth breathe during a run, like it was almost like, where's my gas? Like it's like it doesn't feel like you're getting the energy that you need. Like the oxygenation is not as efficient. And so it's like, you know, the only time I would ever breathe through my mouth is if I was literally at a dead sprint. You know what I mean? Like just the volume had to, and at that point, like it's like a dog panting, right? You're breathing in and out so fast that it's like, you know, there's just tons of oxygen. But like for normal runs, if you're just kind of like, you know, zone 2 workout kind of thing, you know, yeah, if you're used to nasal breathing, if you train your body to be used to nasal breathing, and then you start mouth breathing during a run, maybe you get a phone call, maybe whatever it is, like you're going to feel exhausted afterwards. Like, well, I'm like not getting enough air. And so it's very interesting. So there's a whole book on this. It's called The Oxygen Advantage. I didn't write it, but I did read it. It's by an author named Patrick McCowan, who does a lot with in this space as far as airway.
Sounds like a
physiology.
good future podcast guest.
There you go. Hey, I'll put you in touch with him. Yeah.
Do you know him?
So you know it's funny. So you know, you roundabout and whatnot. So I've never actually met him personally, but I did actually get in touch with his team because we were working with. Long story short, I met a producer for Drew Barrymore. Blah 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 blah. So I ended up getting put in touch with this team because they may sponsor a segment where we actually talk about mouth tape, and so that's still kind of in the works.
Yeah.
But yeah, I ended up getting in touch with his team. So I haven't met him personally, but I could put you in touch with his team. So
Love that. Great. Okay. Well, we have something to look forward to then.
there you go.
So how do people find you? You mentioned your book. Say that again.
Yeah. So
It's called-
Airway-Focused
Yep.
is the name of the book. So my website is vegasorthodoc.com. That's a website specifically geared for patients who are interested in this space. And so it's for locals and non-locals. So patients can go onto the website, and if they're curious or if they just want to know, like, am I a candidate for expansion? Do you think I need expansion? Do I have airway constrictions? Like, what does my nasal anatomy look like? Tonsils and adenoids? They can just upload their imaging from anywhere in the world. and we can review that together and just send them a consultation. Like, hey, this is what I think about your case. These are the questions I would be asking. These are the specialists I would consider seeing. And then our practice name, where we actually practice here in Las Vegas, is Hamilton and Manuele Orthodontics. So that's our local name for our practice here in town.
So cool. That's awesome. Thank you. Thank you so much for the great wealth of knowledge today. I think that's going to be transformative for me. And I love to be able to just sit down and have a great conversation and learn all these things. And I'm sure hopefully anyone listening to this took a lot away from that as well. So thank you.
Yeah, well, my pleasure. And thank you for having me. As always, you're such a gracious host. And I love how much you love to really explore things and to really dig into the details and help your listeners really understand, not just surface level kind of chat about, but really to understand and dig into these topics in a way that's going to make sense to them. So thank you.
Yeah, we got to know the why. We
Yes.
got to, we mean that the why is important to growth,
It
right?
is,
And we
it
talk
is.
about built for growth. We got to understand why. I hate nothing more than to just be told what to do and not understand the reasoning behind it. And I find when I understand the reasoning behind it, then I can maximize the request.
Yes. And make it more sustainable.
Correct.
Yes.
And I could really understand what the objective is. Like, what am I actually trying to accomplish and how is the mechanism of action working? And then that cues me into just my awareness in my own body. As I mentioned, some of the things that I was trying to do was strictly from a performance standpoint. And then I realized that my intuition and the things that I learned just from my body's feedback, like, oh, wait, when I fight with my own nasal passageway before I go to sleep, it clears up. Never knew that. That's interesting.
Light bulb moment.
Yeah, it was a light bulb moment for me. I was like, okay, so I have some say in this. This is not just something that I have to suffer with.
Yes.
That I can't breathe well, that I don't smell things. I still remember, the first few times that I would smell. I would walk into a room. Sometimes it wasn't pleasant, and sometimes it was. Sometimes it's like smelling cherry blossoms in Washington. Just like walking outside and being like, oh my gosh, wow! Like not because I was trying to smell anything, but because I was breathing through my nose.
Right. And, that vasodilation, it has an effect, of course, on oxygenation like we talked about, but you look at the smelling pathway mediated by blood flow, right? I mean, these molecules are going into it, and all of those are mediated by blood flow. So if that blood flow is constricted due to mouth breathing or whatever else, then all of those senses are going to be diminished.
Yeah, absolutely. So cool. Thank you again. I know I've said it a million times, so thank you, and I'll let you get out of here. It's been great. And I appreciate you. And
likewise, thank you. Thank you for what you're doing. Thank you for being there, resource. I mean, I've loved listening to your podcast over these last few months. So cool transitioning from, just really taking one thing you're great at and then transitioning to an entirely different space, but still being able to share your talents with others in a way that's meaningful is just really inspirational. So
thank you. That's the goal. So we'll be in touch, and maybe I'll bring Amaya by.
there we go.
Yeah, get
Happy
her
to see you.
assessed.
Yeah.
Okay, thanks.
All right.